Hi, everyone. Thank you for joining us today. I'm Jake Piasecki, Director of Business Development at Conway Wealth Group, and just wanted to cover a couple housekeeping items before turning it over to Michael Conway to kick off our event today with WorldClinic. Thank you to those of you that have submitted questions with your registration. They will be answered throughout today's discussion, and we will also be accepting questions throughout the presentation that can be submitted in the question drop-down within your GoToWebinar navigation panel. If the questions that were submitted ahead of time are answered over the course of the presentation, we will defer to the doctors and we will skip and go to the next question. But one other thing, the thoughts and opinions expressed by WorldClinic in today's webinar do not necessarily reflect those of Conway Wealth Group. WorldClinic is a privately owned company which is not affiliated with the Conway Wealth Group or Summit Financial LLC and affiliates. The information and opinions discussed today have not been verified by us, nor do we make any representations as to their accuracy and completeness. Check with your own personal doctor before making any medical decisions. So with that said, I kick it over to Michael Conway to kick us off with some of the fun stuff in this discussion around COVID-19.
All right, good deal. Thank you, Jake. So, hey everyone, I am Michael Conway, founder and CEO of Conway Wealth Group. Thanks everybody for joining us for this special webinar with our Life and Wealth Network member, WorldClinic. Today we're excited to present to you WorldClinic's founder and CEO, Dr. Dan Carlin, along with Chief Medical Officer, Dr. Bill Lang, for a discussion on navigating the COVID-19 pandemic. As we all continue to deal with the direct and indirect effects of the virus, many of us have struggled to tell the difference between fact and speculation, especially as the pandemic has unfortunately become a political minefield. So today, we're looking forward to hearing directly from two of the nation's top physicians to help clarify some of the facts and to offer guidance as to what we might expect for our future and our new normal. So with that, Zach, I'll throw it over to you.
Hey everybody, thanks Mike. My name is Zach Conway. I'm the Managing Director of Conway Wealth Group. As a lot of you know, Conway Wealth Group focuses on the idea of aligning life and wealth. So with our clients, we spend a lot of time quantifying not just the investment gains in an investment portfolio, but gains in the parts of life that we think create lasting happiness for families. We do this by having important conversations and ensuring families have access to the appropriate professionals along the way. That's why we created the Life and Wealth Network, which consists of what we feel are the nation's best and brightest service providers in these different areas of life. With health obviously being a #1 concern for many of us in these unprecedented times, we're proud to have a fantastic organization like WorldClinic as a member of the network, and we hope you all can gain some valuable information today. So before turning it over to Dr. Carlin and Dr. Lang, just some quick background. Dr. Lang has been a family physician for over 30 years, and he's recognized as a foremost expert in health aspects of contingency planning and response to critical incidents. As the director of the White House Medical Unit and deputy physician to the president, Dr. Lang was responsible for organizing and providing comprehensive healthcare services to 2 US presidents and their executive staffs. Later, as Associate Chief Medical Officer of the Department of Homeland Security, Dr. Lang played a key role in the department's implementation of the nation's preparedness strategy. Simultaneously, he was often the on-call physician for senior leadership, responding to all healthcare concerns that arose. Dr. Daniel Carlin pioneered WorldClinic's innovative concierge telemedicine model after a decade of experience in the demanding healthcare environment. He's a national leader in the field of telemedicine and a recognized pioneer in the delivery of medical care to distant populations. He's a board-certified emergency physician and a former US Navy medical officer. Dr. Carlin's work has been featured in Businessweek, Forbes, Fortune, the New York Times, the Wall Street Journal, and others. And he's also been a guest speaker on shows like The Today Show, Dateline NBC, and The Oprah Winfrey Show. So with that, Dr. Carlin, I will pass it over to you.
Great, thank you, Zach. Well, thank you for joining us today. Dr. Lang and I have a unique perspective on COVID, and maybe I should start out by saying our perspective is reality-based. There's a lot of political viewpointing going on, I guess, or opinionating around COVID. I have no interest in that for today. Today, we're going to talk about what's going on with COVID, and I want to give you some sense of our background, where we're coming from. So I'm a physician. I run a very unique medical practice called WorldClinic. It is sort of the equivalent of concierge telemedicine. The clients are high net worth families, C-suite executives. They've hired us to take care of them on a global basis, worldwide, and to essentially render some efficiency and most certainly accountability to their healthcare. Now, we are a global organization, and we started noticing COVID at the end of December. And by the end of January, we're growing concerned, actually more than concerned, in the sense of we knew we were going to have to react. So we were one of the earliest groups, I think, that were actually tracking this in the context of a clinical practice of medicine. I think that's maybe one of the hardest parts, is because our goal is we've just got patients to take care of, and we need facts, we need objective information to take care of them and to do a good job. That has been somewhat challenging, and Bill is going to fill you in on what some of those challenges have been. But I want to just pause for 1 second and say, okay, we're coming out of a reality perspective, and I actually want to talk about my industry for 1 minute. This is the best thing that ever happened to WorldClinic and the entire industry of telemedicine, and I'll tell you why. Because of COVID, people could no longer think about accessing healthcare through the local physician's office, emergency room, or urgent care. They could, but there would be a risk that would be associated with it. And this actually is now toppling a very dysfunctional healthcare system, or order of care events, if you will. And it's essentially distributing healthcare out of the physician's office down to the connected phone. This is a huge event. Now, this happened in virtually every other industry about 10 to 15 years ago, but it is now finally coming to healthcare, where your smartphone will be your portal to access physician expertise, organize your medical records, track and manage your chronic diseases. We have a front seat at this. It's incredibly exciting. It's also going to be transformative and disruptive. But if there's a silver lining to COVID, it's that when this is all over, we will be at the beginning of a whole new way of practicing and delivering healthcare. So having said that, let's get back to COVID. My goodness, there's a lot going on. A lot of our assumptions at the beginning were completely wrong. We were absolutely misinformed at the very, very beginning by parties who should have given us the responsible truth. I'm not going to go too far with that. What we need today is facts, and we need facts from an objective expertise. My colleague, Bill Lang, he's a superstar. It's not just that he's my colleague. I've known Bill for years. He comes out of the White House, Department of Homeland Security, but mostly he's a family practitioner. I'm an ER doctor. We tend to be a little too blunt, a little too direct, a little too hard on the patient. Bill's in family practice. He's a master communicator, grounded in facts. And that's exactly what we need right now. So Bill, without another word, all yours.
Well, thanks, Dan. And that is what I try to do with coming from the family medicine background. Is taking all of these issues, these opinions, these studies, and put it together so people can figure out, okay, what I can explain to people, what's really going on. What I'm going to try to do today, just 9 slides. I always like to give people an idea of what to expect. So with 9 slides, we're going to talk about what is COVID-19, how do you make sense of it, and then go through where we are today, talk about testing, talk about vaccines, and then talk about where do I think we're going over the next few months. So with that, let me get the screen up and just make sure if someone give me a thumbs up. Yep, we got the screen up. Okay. So the first thing is that just a couple of key baseline comments and concepts is first, the name of this, COVID-19. Well, that's the disease. The virus is actually SARS-CoV-2, or the sudden acute respiratory syndrome, coronavirus number 2. That's just too much to say. So that's why we say the SARS-CoV-2 is the name of the virus which causes the disease COVID-19. But importantly, while we say this is a pandemic, it can't be managed as a pandemic. It's got to be managed as a series of linked regional epidemics. Each region has different characteristics. There's characteristics of the population, the demographics, and the family styles. For example, early in this epidemic, Italy was hammered. Why was Italy hammered? Italy was hammered because its population is about 6 or 8 years older on average, especially in the region, northern region where it was hit hard, about 6 or 8 years older on average than our population. That's a huge, huge difference. And they tend to have multi-generational families. So everybody was one on top of another. That's what really hit hard in Italy, as an example. But you have lesser differences when you look at other parts of the country, of the world. So it's a regional. The other thing, the characteristics of the environment in regions can be different. Simple things like temperature and humidity, but also how conducive is it to just be outdoors more? The more you are outdoors, the more you're separated. And then also there's one other thing you can't ignore, and that's the behavior characteristics of the population. Is this a population that's going to follow the guidelines that we're giving them? Are they going to get immunized, or are they going to be resistant to immunization? So all of those things, they all fit into making this not a single pandemic, or it's not even a single national US level epidemic, but it's a series of linked regional epidemics. So then the next question is, well, people want to know what do I need to do to be safe? Well, the first question to that is, what does safe really mean? Because what's safe to one person might feel very dangerous to another. It's all about looking at risk tolerance. There's the risk of becoming infected, and then there's the risk of severe disease if you are infected. And then some people think of it as a third dimension, and that's, well, what's the risk of transmitting the disease if you're infected? But those are all different risks, and you have to think of them differently. The young person, the 17, 18-year-old, in some ways, and I'll talk a little bit more about this, they don't care if they get infected, but the care for them is who might they infect, parents, grandparents, things like that. So you have to think of risk. You can't think of it in one dimension. You have to think of it in multiple dimensions, because the idea of eliminating risk is a fool's errand. The risk of second and third order effects are often significant, and they're overlooked when you try to think about the primary risk in dealing with COVID-19. But you always got to think of those second and third order effects, and then you've got to look at risk, not absolute safe or non-safe. That's not a binary question. Now I'm hoping, there we go. So a couple statistics to put this in perspective for you. First, number of US cases, the total diagnoses since this has started. You always see, when you look at CNN or Fox News or whatever you're looking at, you see these big numbers. What does that really mean? Well, the total number of people infected so far is 1.7% of the US population. But think about that a minute. I mean, I think the way it's portrayed on TV, you're thinking that every next person you see is probably had COVID. Oh no, 1.7% of the US population has had COVID-19. And of those, 80% of those needed no kind of special care whatsoever. They had basically cold, flu. Now, sometimes people minimize that. These may be people who are pretty damn sick at home, but still, they didn't need any special care. Then another 15%, they need outpatient care, meaning they need to go to the doctor's office and maybe some special assessments, maybe some medications to make them feel better, or in fact, to treat things. But then only 5% have needed inpatient care. So let's take that a step further. So what is the proportion of the US population that has been hospitalized for COVID at any point? It's 0.11% of the population. And if you look by age group, so 18 to 29, young adults, 0.03% of the population. You roughly double that for the next 10 years and roughly half again for the next 10 years. So still, when you reach the 40 to 49-year-old age group, you're still less than 0.1% of the population who needs hospitalization. So pretty small numbers. And then when you look at it also, that of those percentages, 94%, they needed inpatient care. They had some other medical issue. So the young person who who is healthy, and even the older, not, I won't say geriatric population, but even the older person who is healthy, does not have significant medical issues, their chance of being hospitalized is pretty small. And the real chance of needing special care, needing ICU care, if you are not in a high-risk group, it's 0.001%. That's a pretty small number. So when you're thinking about COVID-19, it doesn't mean you minimize it. It doesn't mean you ignore the risks. It means you keep the risks in context. So the big thing is, well, how do we get to where we are now in the midst of this reopening phase? Or sometimes people don't feel like they're reopening anymore, but we are. We're in the reopening phase and we're still trying to move forward. The analogy that I've heard used a lot, and I really like, is the hammer and the dance. The hammer, that was what we did in March. That's when we came out and we shut down everything. The idea being that the cycle of this infection, from the time you're infected through all the time that you can infect other people to the time that you're better, is 2 weeks. So therefore, if we lock down everything and we don't let anybody touch or be around anybody else for 2 weeks, in theory, you would kill the disease and it'd be all over. Well, of course, we can't hermetically seal everybody in their homes for 2 weeks. There's still going to be some transmissions. That's why we got extended that out to 4 to 6 weeks, depending on where you were. But that was the hammer. Shut it down, stop transmission. And it worked to some extent. It really did take the top off that curve. It flattened the curve, as we talk about. But then from the hammer, we went into the dance. The whole idea of the dance, and we're still doing the dance, it's open up a little bit, check the data. Are rates going up, rates going down, rates staying flat? If rates are staying flat or going down, open up things a little bit more. Do that over and over again. And you get to the point where you start to see rates maybe start to creep up a little. You can just reinforce to people they need to take care of themselves. They need to wear masks. They need to take various measures to reduce their interaction with others. But you do those things and you can keep opening and opening and opening, but you do it slowly. But what the biggest thing that you debate is, what is that data set? What is the important data that you're looking at to decide whether you're going to open or not? Is it strictly the number of cases? Well, if that's all you're looking at, you're probably not going to open much, because you turn the throttle a little bit and you're going to have cases run up. You've also got to look at things like, what are the rates of suicide and people who are being kept in lockdown in their home? You know, those are other effects that you need to think about. So looking at this data set is the important part of deciding, do you open, do you not, do you just keep things the way they are? And that's what the local governments, and the emphasis being the local and state level governments, because again, this is not a national epidemic. This is a series of tightly linked regional epidemics. So the big phase that we are at right now in reopening is, do we reopen schools and universities? Let me give you one perspective to keep in mind as we go through the decision on opening schools and universities. So let's start first, and I think it's important when you look at schools and universities to think of 3 levels: elementary, high school, and then colleges, university level. In 2017, 2018, that was the last bad year for a flu. So that's not the average year, that was a bad year for flu. But that's only 3 years ago. That's still fresh in people's mind. There were 528 deaths from influenza alone in school-age children. So far in this epidemic of COVID-19, there have been 56 deaths in school-age children. And we're still looking at a pretty comparable length of time. Yes, now we did close down the schools, so that reduced the interaction to a great extent fairly early on. So that is granted a difference between the two. But still, kids are kids. Kids, especially over the course of the summer, have been interacting. They've been out playing. I go to my neighborhood, and there are kids everywhere, and they're doing things that kids do. But by that measure, influenza is significantly more dangerous than flu. We're not closing down the schools to protect us from influenza. So are we going to do that for COVID-19? But here's the deal. The real issue is not taking care of the kids. Kids don't get really sick. Kids in general don't die from this. Yes, there will be a tragedy, truly a tragedy of a child or children who will die, and it's somehow related to COVID-19. Remember, that's already happening to things like influenza. But so this isn't about protecting the kids. It's about protecting the staff and the faculty that have to be around these kids who may be more at risk. It's about the kids bringing home the disease to potentially at risk, their grandparents, maybe their parents if they have other medical issues, maybe siblings that may have medical issues. That's what we need to worry about. So when we talk about reopening the schools, let's keep an eye on when people say it's all about the children. Well, no, it's not. If it's all about the children, we're going to send them back because they are really losing out on the socialization skills, the in-person learning, the hands-on learning kinds of things. But it is about watching the effect of the kids on everybody else. So keep the arguments in mind, and again, recognize that the same argument, the same decision is not going to be equally applicable to every school district across the country. It's a series of linked regional epidemics. They have to be managed locally. What about reopening businesses? When you think about businesses, and that includes office-based businesses, that includes retail, it's all about decreasing the density, decreasing the amount of opportunities that people have to be in close contact with one another. As we've learned over the past 6 to 8 weeks, it's not about the touching surfaces and you touching the doorknob that someone else has touched that may have been infected. Yes, that probably has a role. We're pretty sure it has some role, but it's really about close contact because this seems to be more of a airborne droplet spread. So what can you do? It's all about what can you do to make it easy, make it feasible to keep people apart. You know, at least 6 feet apart. You never want people to be closer than 6 feet. And if they're closer than 6 feet for more than 15 minutes, then that's a significant risk. That's where you have to start thinking about putting people in quarantine if they've been in contact with people who are sick. But what can you do to decrease the head count, so to speak, in various places? Working at home when feasible. I think one of the things that Dan has mentioned is that as you can virtualize functions, do you really need to have people one on top of another in the old style cubicle farms? I say old style because I really think that those are going to be gone, because a lot of those kinds of things, you don't need to be one on top of another. You can be either distributed to home or in distributed smaller offices where social distancing, physical distancing is much more possible. So what can we do to virtualize and decentralize work? As I talked a few minutes ago about the death rate in children with influenza, when you look at it on an annual basis, the amount of lost productivity due to infectious disease like influenza means that this need to spread things out a bit is going to be with us forever, because we're always going to have some level of infectious disease. So this is a change that I think may be pervasive throughout the business world going forward. But what can you do in addition to just being physically distanced? Masks probably do something. You know, early on there was the huge debate. Initially they said don't wear masks, and it turned out that we were being told don't wear masks because we wanted to make sure we kept the masks for medical people. But masks do have benefit. Then we were told the masks are only beneficial to prevent you from giving the disease to somebody else. Well, now we're finding that, you know, in reality, masks probably are protective. Not 100% protective, but they reduce your risk. And everything we're doing, again, it's not about eliminating risk, it's about reducing risk. So masks do reduce risk, both of transmitting it and of becoming infected with disease. Hand hygiene. Again, it's not that surfaces are so important, but they're not unimportant either. So hand hygiene, washing your hands whenever you can, using hand sanitizer when you can't wash your hands. Minimizing the close person-to-person contact. Now that doesn't mean isolating yourself. Things like what we're doing now are very effective ways of having contact. Yeah, we're gonna need to get back to where we can press the flesh, as the saying goes. But for now, as long as you can maintain contact with people, it doesn't need to be person to person, especially within six feet. In businesses, if you can optimize ventilation, that doesn't mean putting in huge new HVAC systems. That doesn't mean putting filters all over your office. It just means running the systems the way that they're designed to be run. There has not been any demonstrated transmission of virus through HVAC systems. There are other diseases that have been. It's not generally a big issue. It has happened, but that's not typically big. And then the other thing is screen, Check that you don't have any of the symptoms of COVID-19 on a daily basis. Everybody who comes into the office, employees and visitors, tell people to stay home when sick. So those are the things that will allow us to reopen businesses, and is allowing us. I think we're seeing what the GDP is doing. It's going up because businesses are reopening. One of the biggest questions that I get as we talk about COVID-19 is testing. Well, there are two, and this has been all over the news, but I still find that people are very confused about this. It boils down to there are two kinds of tests. Within those are subsections, but just there are two kinds of tests. One is tests for the presence of disease. The other is test for antibodies. That's testing for did you have the disease. So the test for presence of disease, that's the nasal swabs and throat swabs, or some people have called them brain biopsies, where they stick a swab and get it as far back in your nose as they can, because that's the area where there's the highest concentration of virus. But even with that, there are a couple of different kinds of tests in there. There are these PCR tests, polymerase chain reaction tests, and then there's antigen tests where it actually looks for the presence of the proteins that are on the virus. Two different kinds of tests, both are very efficient in giving you an answer as to are you infected or not. The PCR tests are the gold standard and are more effective than the antigen, but they're both useful. And there's types of samples. There's the swab tests, and those are the ones that everybody's used to. But what's coming on now through a test out of Rutgers University, and now just last week, a test that was developed at Yale, is saliva tests, which they are looking like they are going to be almost as effective as the swab tests at 10% the cost. The thought is that the saliva tests can be done for basically $10 a piece. When you start getting to that level, they're not available yet, but when they start getting to that level, then you can start having truly massive testing programs pretty quickly. But then there's the types of process. There is a lab-based test. That's the swab-based PCR tests are usually run in big labs on big lab machines. And then there's the office-based test where you walk into the office and they stick in a small machine in the office and they can run one test at a time. And then there's what's coming on that we'll probably have within the next 4 to 6 weeks is a point of need test. And that's more like a pregnancy test. A cassette, you put a sample in it, you put some fluid on that, and a few minutes later you get your answer. You're saying 4 to 6 weeks. The logistics of it concern me a bit. Can we get there in 4 to 6 weeks? But still, over the course of this year, we're going to have those kinds of tests. They're not going to be as accurate, but if they're pretty good, that'll be very useful for doing screening. So then there's the antibody testing, and that's a blood test. Antibody testing is always a blood test. If someone's sticking the needle in your arm, they're doing antibody testing. They're not doing testing for presence of disease, at least with the way it is currently. And that's telling you, are you infected? Have you been infected? It does not tell you, are you infected? Then the big question is, if you have antibodies, are you immune? And CDC still consistently tells us, CDC, the US Centers for Disease Control and Prevention, still consistently tells us you cannot assume that you are immune because you have antibodies. Now, all the data is telling us that almost everybody is at least relatively immune. Relatively immune means if you get infected, you are probably not going to get really sick, and you are probably not going to be infectious. But because those probablys are still in there, we don't want people to make assumptions and change the way that they are preventing transmitting the disease to other people. You still need to wear masks. You still need to social distance. We're hoping that before long, we may have enough data that tells us, yes, you are relatively immune and you can back off some of those things. But we're not there yet. I think that that's what's going to be the case. But we just need to wait a little while longer. And even if you've had COVID-19, still do all the protective measures. Now, here's where we start talking about the big changes that are coming down the pike. Vaccines. Right now, currently, there are 165 vaccine candidates out there. And really, that's probably 160 more candidates than we need. We want to have at least a few out there, and there may be some others that come on, they're more useful down the road, but right up front, we just need 1 or 2 vaccines to get through the process. The process I'm talking about is 5 major phases. One is the exploratory, that's strictly lab-based. For COVID-19, much of that was already done because we had a previous coronavirus. That was the original SARS virus. That was 10 years ago. A whole lot of research was done on that. That research was very transferable over to where we are now with SARS-CoV-2. Then there's preclinical research where you actually, typically, you're doing it in petri dishes and you're giving the vaccine to animals and you're seeing how they react. And then you get into the clinical research stage. Obviously, none of that started until well after the virus was characterized. And this is usually a process that takes at least 2 years, sometimes 5 to 10 years to get through. We're trying to compress that into several months. Phase 1 is where they give the virus literally to tens of people, maybe 10 people. And what they're doing is just checking for safety. I mean, they think it's safe because they're giving it to the animals, but you still get these 10 to 20 brave souls who say, yeah, stick it in me. And they get it and make sure that those people don't grow a third eye. That's the safety study. That's usually done fairly quickly because bad things tend to happen quickly with immunizations. We were okay on this one. That then goes on to the dosing study. What size of dose do you need to get an adequate response, demonstrate immunity? And that's typically hundreds of people. That was done over the course of April, May. We moved into the phase 2 on many of these vaccines, on the key vaccines at least. Then phase 3. Phase 3 is tens of thousands of people. Specifically for the vaccines that we're looking at, it's 30,000 people for each of these vaccines that we're studying. And what are we studying? What are the ones that are in phase 3 right now? There's 3 major ones. And I should say 3 major ones that are from the US, European, North America, Europe countries, and that's Moderna. Moderna is doing a vaccine in conjunction with the US National Institute of Health. That vaccine is a totally new type of vaccine. It's a vaccine called messenger RNA, where it's this messenger RNA is injected in your body and it tells certain cells to make proteins, not viruses, but proteins that match the proteins on the outside of the virus. And then your body makes antibodies against these viruses, these proteins. Those same antibodies will kill the virus. In theory, it's a really good vaccine. And in fact, the nice thing about it is this messenger RNA degrades and goes away. And once it's done its thing, it's gone. So you don't have to worry about it sitting around and doing other things. The next one is AstraZeneca in conjunction with the University of Oxford in England. They've developed a simian adenovirus vaccine. Now, what does that mean? That's a monkey cold. It's a monkey cold vaccine that it's not effective in propagating in humans, very effective in causing colds in monkeys, not effective in causing colds in humans, but they've made it so that it carries the markers that are the same markers on the coronavirus, so your body does make antibodies to that. And the last one is a similar vaccine, but with a human adenovirus that has been made so it doesn't cause a bad cold, and that's BioNTech in conjunction with Pfizer. BioNTech's a German company. Now, you've probably heard the news about the approved vaccines. Well, this is one Russian vaccine and one Chinese vaccine. They've been approved, but they actually never went through any phase 3 testing. They went from the first human trial to saying, yep, let's go forward with this in 60 days. I'm personally not standing in line to be one of these phase 3 study volunteers. They're otherwise calling the Russian and the Chinese population. We'll see what happens with those. They may work. The Russians especially are very good virologists. So it may work, but I'm going to wait for the Moderna, AstraZeneca, or BioNTech vaccines. And by the way, on the vaccines, things are looking good. And I'll talk a little bit more about that on I think my last slide. The other thing that people are asking about a lot is travel. When can I start traveling again? Well, there's a lot. One of the things you have to know when you're traveling is there are many countries and states that are putting in travel restrictions and quarantine restrictions. Make sure that you know what those are. They're not always completely numerically and scientifically driven. So you got to figure out what the rules are first. But for numbers, remember the numbers 1, 10, and 25. Just know those numbers. And what they represent is cases per 100,000 per day. And this is things that you can find easily in the newspaper, on websites. Washington Post publishes this number for every state every day. And if you go to if you're traveling to a specific county and you want a more specific number, almost every county or major city in the US will publish their case rate. And if you look at those numbers, 1, 10, and 25, and the 4 groups of that make, less than 1, it means it's negligible. You don't have to worry about it, really. That's New England in the US. New England is they run from 1 to 3. There is so little transmission in New England. It's basically people coming into New England and bringing the virus with them in New England. So very safe. 1 to 10 is sporadic community transmission. That means if you're out there, pretty low likelihood that you're going to catch it, but it's there. So you're probably still best using the mitigation techniques. Then 10 to 25 per 100,000 per day, that's controlled high rate community transmission. It is definitely there. You're going to be safe if you wear masks, you stay away from other people, you maintain physical distancing, you're going to be okay. And then greater than 25, that's uncontrolled community transmission. Those are places where, generally speaking, the rate's still taking off. Africa is in that. So most of South America is in that. North Dakota, Mississippi, Virgin Islands, and Guam are in that. Greater than 25 cases per 100,000 per day. But use those as gauges for where you're safe to travel to. Less than 1, don't worry about it. 1 to 10, worry about it, but you're probably okay. 10 to 25, I probably wouldn't travel unless I had to. If I had a business reason, I would do it, but otherwise I'm not going to do it. I'm not going to want to go do it. Greater than 25, that's a no-go zone for now at least. And then where do you pick up the risks in travel? Planes? No, planes are actually, the plane themselves are actually very, very safe. And this is the way they have designed the airflow in planes, that it takes the particles down to the ground very, very quickly. I won't go into the details on it, but planes are generally speaking very safe, especially if everyone's wearing a mask. But airports, that's actually with air travel, the most dangerous spot is felt to be the air bridge going out to the airplane, because everybody crams in there. There's very little ventilation. You've all been on air bridges. You know what I'm talking about. That's actually considered to be a relatively less safe spot. But that's not even too bad. Beaches. Beaches are safe. It's not the beaches. We've all read about these outbreaks that have occurred after Beach Week and outbreaks that are occurring the Florida beaches, all those kinds of things. It's not the beaches where the transmission's occurring. It's the après beach. It's the bars, the nightclubs, people getting together for parties. That's where the infections are occurring, not the beach themselves. Again, in this case, it's what you're doing, not where you're doing it. Hotels, again, because it's not the direct surface transmission, it's the person-to-person, hotels are usually good. Events, outdoor events, generally pretty safe. Indoor events, well, in fact, most of the big transmissions have happened in indoor events, board meetings, conferences where lots of people in tight space, not great ventilation. And then the worst of all, bars and clubs. That's where there are many, many of the large outbreaks have occurred in bars and clubs. Last slide. Looking forward, where are we going to go? Are we going to have well, people still say the second wave. I'd say it's really the third wave, because we had the first wave in March, we had a second wave in July. Are we going to have a third wave in October when everyone starts going back to school, back to work, when it starts getting colder and people are driven indoors? Well, those are all the factors that we look at. We say there's the possibility of a second wave because, well, that's what we've seen with other respiratory viruses. They tend to have this wave as people go back inside. The one thing we know with this virus is it's breaking all the rules. It's doing everything different. If people continue to do the mitigation approaches that we've talked about before, that's really going to reduce the risk of a second or third wave. Is it eliminating it? No. So I'm not going to say I'm betting the farm that we're not going to have it. I'd make a bet, but I wouldn't give long odds on it. What are the game changers that can happen? Testing. Just last week, the admiral who is the Assistant Secretary for Health, he's a public health service admiral, so a career public health service officer. He said we had new testing techniques, and this is what I had talked about earlier with these relatively inexpensive saliva-based tests that can be run very quickly and give you results quickly. He said that's a game changer, because once you can diagnose people immediately, get them into isolation, figure out who their contacts were, and put them in quarantine, that can cause the rate to plummet, the transmission rate to plummet. So that may be a game changer. Therapeutics, medications and techniques used to take care of people. There aren't any game changers that anyone's aware of. Now, something can come out of left field, but there's been a lot of research on what medications make a big difference, and there's two. Remdesivir, which is an antiviral, which only seems to be helpful for people who are really sick, and then dexamethasone, which is a steroid, which decreases your body's response to the virus, so you don't get overinflamed in your blood vessels primarily. They have been game changers. They're not a new game changer coming down the road. And then the whole concept of herd immunity. Are we reaching a point where enough people have been sick, have been infected, and now have at least a relative immunity? That may be a game changer. What's happening in New York? I mean, New York right now has one of the lowest rates of disease in the developed world. Is that because people were so sick and so infected back in March? You know, by measurement, we're not there, but something's going on. So herd immunity may be developing more rapidly than we think. Emphasis on maybe. And then the vaccines. I said I'd talk about the timeline. October, we're going to have the first real emergency use authorizations. I'm discounting the Russian and the Chinese. So October, it's approved. We already have money allocated, the systems put in place to manufacture and distribute vaccine. So by December, as long as one of those three major vaccines comes through the pipeline and looks like it's working, and right now it's looking like they all will, but at least one of them, if it comes through this phase 3 study safely, then by December we're going to start high risk distribution to the high risk people, large scale manufacturing distribution of the vaccine. Get that to the high risk people. Over the first quarter next year, we'll have the large scale programs, very similar to the flu shot programs. And then by April, I jokingly say, take me out to the ball game, because I think that in spring, and I'm not going to say specifically beginning or end of spring, but by spring, that we're going to have herd immunity through natural virus as well as enough people vaccinated. So we are going to have, I think, this is, you know, we'll see in 6 months if people are throwing things at me. But I think by April, we're going to be playing baseball and going to ball games. So that concludes it. See, my last parting shot here is get a flu shot. Because remember, flu is still more pervasive. It makes more people sick than COVID is. So get a flu shot this year. Australia and New Zealand drove their flu rates from being very, very comparable to ours to near zero this year. They did it by using the same preventive techniques that we're using for COVID-19 and by boosting the number of people in their societies that got shots by 50%. Literally 50% more people got flu shots in Australia and New Zealand. Get a flu shot and it'll make a difference this fall. That's all I got, and we'll open it for questions.
Great, thank you, Dr. Lang. Appreciate that. We have some questions coming in from the audience and some additional questions that were shared with us at the time of registration. So one of the first ones, and it's pretty newsworthy and timely, that came, I think, yesterday. There was a question, can you speak to us a bit more on the recent news of the FDA giving emergency authorization to treat COVID-19 patients with convalescent plasma and what that means?
Sure. So convalescent plasma is it's not a new technique. It's a very old technique. We needed to make sure that it works with COVID-19. But what it is when people get sick, especially people who get real sick with it, their body makes antibodies against it. Well, it's possible to very safely take their blood, take the serum in their blood, and from that, you concentrate it down until what you've got is just a concentration of all their antibodies, which after they've just been sick with COVID-19, most of those circulating antibodies are going to be against COVID-19. And you take that, it's been processed so that it takes any other disease products out of it. It takes basically any other cellular product, so you can't, it's almost impossible. I never like to say always or never in medicine, but it's almost impossible to transmit any kind of disease with this. And then you inject all these antibodies into somebody, and these antibodies work just like they were naturally developed antibodies, and they kill the virus. They stop the virus in its tracks in the body. And the body still continues to see this antigen, still continues to make its antibodies by itself, but now it's not overwhelmed. So they become a bridge to get you from no antibodies to somebody else's antibodies that have been injected into you to making your own antibodies to disease over. So that's what these are. I didn't throw that in there as a game changer because it's only really going to be useful for the people who are who are more sick. You're not going to be giving convalescent sera to people who are just mildly ill. And frankly, we've reduced the death rates in those really sick people already. So is this going to be a game changer? I don't think so, but it's going to be important.
Okay, great. Another question that was posed is, there was some talk, and there is still talk about underlying conditions, and obviously people being at a greater risk. Has anything changed, and is there a specific underlying condition that is really affected more so with COVID-19?
There's a lot of back and forth. What are the key underlying conditions that cause problems? When we started this whole thing back in the March, April timeframe, and initially the ones that were thrown out there were the usual suspects. I mean, do you have asthma? Do you have respiratory disease? Do you have bad heart disease? Do you have diabetes? And those were just assumed that, well, of course, these are things that make you more susceptible to disease. Pregnancy. Well, now they're cranking through the data, and what we found is, well, diabetes is, for whatever reason, even though their diabetics can have a relatively lower immunity, diabetics tend to do okay. They're not protected, but especially type 1. Type 2 diabetics, it doesn't seem that it's the diabetes that causes problem, but people who are significantly overweight, which is seen more in type 2 diabetics. They tend to, people who are overweight, they do tend to be at higher risk. Asthma does not seem to be at higher risk. We assume that it would be, but it's not. And it may be with the types of receptors that are on their airway cells that are actually decreased. And I'll be the first to admit, I'm a family doc. I'm not a virologist. How that works, I don't know. But the asthma patients do not seem to have a lot of problems. And then the other group that does have problems are people with heart disease. The reason for that, and other blood vessel disease. And the reason for that is that this virus is not a respiratory virus. It is a virus that is transmitted through the respiratory system, but the effects of the virus are causing vascular inflammation. That causes problems with people who already have vascular disease, like people with heart disease. So.
Okay, great. And sort of to piggyback off of that, and we were talking about high risk, is there any, there's been some news, this is the question, there's been some news about this virus affecting different blood types differently. Is there anything you can share with us on that, or is that not substantiated?
No, it's been substantiated that epidemiologically, meaning you just look at the numbers, and people who are positive blood types don't seem to do quite as poorly as people who are not positive, but no one's been able to really tie down exactly what that reasoning is. It may have something to do with some of the genetic sequences that are located in a similar location on the chromosomes of people who are positive blood type, but no one's really been able to figure out what that is. So yes, they're demonstrated that there is a lower risk of severe disease in blood type positives than in negatives, but it's not really, it's why that is, and it's not a huge difference either.
Okay. The next question came through, and I'm gonna read this. This is an audience question. My daughter is in 10th grade, is being told to wear a mask all day in high school except during lunch. Is there any evidence is there any evidence wearing a mask 40 hours a week is harmful? And the second part of the question, what is the best mask to wear? I heard COVID-19 is 0.1 micron in size, and most masks won't keep droplets that size out anyway.
Okay, so There were probably up till about 2 or 3 weeks ago, there was a lot of concern that you're rebreathing the same things, and is that going to cause more infection? No. If you're using an N95 mask, those are the high-grade medical masks. Wearing those for a long time can be very tiring. It would be someone, even a child who has this N95 mask on for 6-7 hours a day, they're just going to be tired. Excuse me. You're just going to be tired from, and that wasn't the way to sneeze. Remember, sneeze into your elbow, not in your hand. So they're going to be tired from breathing, but there is no evidence that they are at increased risk of infection from, or worsening infection from wearing a mask like that. In terms of what type of mask, well, there was an interesting study that came out probably 3 weeks ago now. And when I say study, this was not the most scientifically done study, but it was a reputable university using reputable machinery to try to look at how effective were different kinds of masks. And yes, N95 masks filter out 95% of the particles. Those are most effective, but then you got the problems. What was really surprising was that 3-layer cotton masks, meaning this is my mask. This is a 3-layer mask. It's a layer of cotton, another layer of cotton, and on the inside is a layer of non-oriented fabric, meaning it's a fabric, but it's not all in strands oriented, vertically and then horizontally like regular cotton is. So it's totally manufactured fabric that tends to pick up. You put those 3 layers together, and that's almost as effective as an N95. Now you still get airflow around your nose, and probably if it's bunching up a little bit, you get some airflow there. But the effectiveness of it, especially when you sneeze and it goes out, is very, very effective. And remember that while the viral particle is on the order of magnitude that you quoted, you're not trying to capture every viral particle. You're trying to capture these larger particles that carry the viral particles and keep them from spraying out across the room. So that's what everything is about. Again, as I talked in the early part, it's not about risk elimination. It's about risk reduction. And if you can significantly decrease the viral load that anybody is spewing into the environment, then you're going to significantly reduce the risk to others. And there's evidence that wearing a mask like this actually reduces the amount that you're breathing, the amount of viral particles that you're breathing in. So are you going to stop every viral particle? No, but you don't have to stop every viral particle. You just want to decrease the level.
Okay, great, thank you. And then one last question from the audience that we have here is there a recommended website for accurate data to get updates about whether COVID-19 is growing or declining in my county or area of residence?
So I'll tell you what, because I do this every day, because I'm working with a number of organizations, companies, individuals, and they're asking things like, what is the dynamic in a certain area? What can I do about travel? So we're looking at this every day. So I mentioned earlier, the Washington Post site is actually very good. It gives you exactly the data you need. What are the number of cases per 100,000 per day averaged over the last 7 days? Perfect data set. But it's at the state level, and it includes DC and includes the territories also. So great data at the state level. That'll give you the kind of the macro view of your region. How are you doing? But then if you go to the county, and what I typically do is I type in the name of the county. I'll put in Sonoma County COVID data, and 95 chances out of 100, you're going to come. The first thing you see there is going to be Sonoma County COVID dashboard. That's typically what you see. You open it, and it's going to look different everywhere you go. But what you want to look for is, you don't want to be looking for absolute numbers. It drives me nuts that the news and even many governmental websites focus on absolute numbers. How many cases have we had? Who cares? What you care about is how many cases are there and the direction those cases are going, up or down. And so you sometimes have to poke around a bit on those websites to find it. But usually at the county or large city level, the health department will publish their case rate data, and that's what you want to see. Nationally or at an international level, the Johns Hopkins site is very, very good. You put in Johns Hopkins COVID data, and that'll give you level by country. They don't do a good job of giving you rates, although for every country they do show you the epidemic curve, which is showing you rates. Although it just gives you gross level, it doesn't give you details. So that's what I use for data.
Great, thank you. Well, I think that we're just about rounding the bend here and coming up on our time here. So I want to transition it over to Mike and Zach if there was anything else that you guys wanted to ask here or that you've heard from the audience before we close it out.
Sure, Mike, I was going to ask a question, or did you have a question?
Yeah, my quick question. We've heard a lot about this hydroxychloroquine. I'm not sure. Is that good, bad, indifferent? What's your take on that?
Okay, so I want to be I'm always very careful when I answer questions about hydroxychloroquine, because hydroxychloroquine has been probably one of the most politicized medication ever. There is initially the FDA gave it an emergency use authorization and said that you could use it. There is actually pretty good data that hydroxychloroquine, if combined with zinc and given early in the course of disease, similar to the way we use Tamiflu, where you have to give it in the first 48, 72 hours after you develop symptoms, can be effective. However, we're not allowed to say that. And in fact, in certain states, the governor has made it a contrary to good medical practice to say that. So, is it something that you can advocate? No. And there are plenty of studies of varying levels of quality that have demonstrated ill effects from hydroxychloroquine, specifically some cardiac effects. But if you're looking at if you're working with a physician who knows you, who has looked at your cardiac status and determines that you're not at risk, and it is legal to do so in your state, then I think it is a reasonable discussion to have with your provider. But just recognize, and then probably even your provider might even want to have you sign something, recognizing that this has not been proven, but there may be some benefit. The way I look at it personally, and this is how I answer this one, I would, if I started to develop symptoms of COVID and I had exposure and all that and believed that it was out there, I'd be thinking hard about taking hydroxychloroquine, but I'm making a personal decision based on what I've known. I'd have a hard time advocating this on a wide level. I was on CNN a month and a half ago, and John King asked me, where I was right when the president was given, said he was taking hydroxychloroquine, and he said, "So doctor, would you have supported giving him hydroxychloroquine?" And my answer to John King at the time was, well, if I had access to his medical records and I was confident that he had no cardiac problems and he wanted to take it, we knew what the data was, would I support that? I would. And John King was somewhat astounded that I said that, but I did.
Zach, did you have something?
I do, yeah, and I apologize. It's kind of a 3 questions wrapped up into one. So the rate of the death rate, so lethality, is there any evidence that the disease has, or that the virus has mutated, and that some form of mutation is changing the actual lethality of the virus? And then the other part, some evidence that there are sort of neurological after effects. So once you have the disease, there's sort of the traditional flu-like symptoms, and then some neurological after effects. Any evidence that that is, the case, and what that means?
Okay, so the first one, the mutations. The biggest thing on that was 6 weeks ago now, probably 2 months ago now, the head of the Italian version of the CDC said that it was his belief that the virus had mutated and was in fact less lethal. When they do very careful examinations of the DNA of the virus and of the proteins that are expressed on the virus, they are not finding any such mutations. So there are small mutations, but they're basically just useful for being able to track where the virus came from. essentially. Was it the European strain or was it the Chinese strain? But no significant changes in function or lethality of the virus. Would it be surprising if that happened? No, but it hasn't been observed yet. It's going to continue to be watched carefully. And then, oh shoot, part two question was?
Neurological effects, so symptoms after
what's this phenomena that is developing that's called long haulers. These are the people who a month out are still feeling lousy. Primarily, the biggest complaint has been fatigue. Some shortness of breath, but the biggest thing is that people still a month out feel profoundly fatigued. A couple of thoughts on that. One is that the numbers are really small, but it's becoming a very, very loud group of people. They're developing all the various social media, and they're becoming very, very loud. Now, that doesn't mean just because they are loud and getting out there and making their point doesn't mean that it's bad or it's not bad. There probably are some people who have some lingering effects. No one's really quite sure what that is yet. It is something that certainly and very clearly needs to be evaluated, but it also is fairly certain and fairly clear that it's not that common. So something's happening, but it's not the kind of thing that people should be terrified that it's going to happen to you. So that's, I wish I could give you a better answer. This is an area of very active investigation.
All right, good deal. So with that, we're at the top of the hour. I want to close by saying thank you for everybody for joining today. A special thanks to Dr. Carlin and Dr. Lang for being here and providing their insight on the future of the medicine industry as well as what's happening here with COVID-19. The webinar, everybody, was recorded, so we'll be sharing the recording with attendees in a follow-up email. At any time, please feel free to reach out to us if you have more questions. And in the meantime, we hope you and your loved ones stay safe and healthy, be well, and hope to speak soon. Thanks, everybody.